My talk today will be about the MASH. Is it an endocrine or liver disease? A source of my lectures is from the Society of Endocrinology, the American Association of Clinical Endocrinology, and the European Society of Endocrinology. This is my agenda. So, to start with, the NASH, or non-alcoholic steatohepatitis, is part of a disease spectrum, NAFLD, which ranges from simple steatosis to fibrosis and cirrhosis. NAFLD is now the most common cause of chronic liver disease in Western countries, affecting almost 30% of the general population, and it continues to increase due to the growing obesity epidemic. The principal risk factors to develop NAFLD, which may also be referred to as a MAFLD, the present, or insulin resistance and obesity. It's also associated with some other manifestations like obstructive apnea, hypertension, dyslipidemia, gut microbiota alteration, genetic predisposition, sedentary lifestyle, and consumption of certain foods like the fructose. Nevertheless, some endocrine diseases are also associated with MAFLD and MASH. Here in table 1, there is some endocrine causes. First of them is cortisol excess, even مثلا Cushing disease, Cushing syndrome, أو even حتى لو ندي exogenous corticoid administration, thyroxine لو حتى primary or secondary hypothyroidism, growth hormone في الاكسس وفي الديفيشنسي برضه ليهم علاقة, testosterone as primary or secondary hypogonadism, and lastly prolactin as a prolactinoma with even a stroke effect. وهنبتدي نتكلم دلوقتي على some endocrine causes of MASH. Type 2 diabetes, as we all know, and insulin resistance, polycystic ovary syndrome, hypothyroidism, male hypogonadism, growth hormone dysregulation, glucocorticoid excess, and lastly, some miscellaneous. To start with type 2 diabetes, NAFLD is a major risk factor for the development of type 2 diabetes. Some lipid intermediates like diacylglycerols and ceramide have been involved in the development of insulin resistance. Ceramide inhibits insulin signaling in diacylglycerol and activates the protein kinase C, which is the key pathway responsible for causing the NAFLD-associated hepatic insulin resistance. Diacylglycerol can accumulate following an increased delivery of chylomicroneminants observed secondary to increased dietary intake, and depending on the diet composition such as high-fat diet and a fructose diet. Moreover, skeletal muscle resistance, which can be seen in sedentary individuals, can result in the de novo lipogenesis, which will cause increased diacylglycerol content. On the other side, the liver, essentially an exocrine gland, but also an endocrine gland, produces some important hormones. One of them is the fibroblast growth factor 21. The FGF21 is considered an emergent biomarker of the NAFLD, and this level is increased in NAFLD and correlates with the hepatic triglycerides content. Studies showed that chronic FGF21 administration not only reverses the hepatic steatosis, but also improves insulin sensitivity by decreasing the diacylglycerol hepatic content and protein kinase C activation, suggesting that there is a state of FGF21 resistant in NAFLD. Polycystic ovary syndrome. Polycystic ovary syndrome is an endocrine syndrome frequently encountered in young women with childbearing age. It's best defined by the Rotterdam criteria as oligo or anovulation, clinical and or biological signs of hyperandrogenism, and polycystic ovaries. Studies reveal that there is a significantly higher risk of NAFLD in women with PCO independent of obesity and might be correlated with hyperandrogenism. Hyperandrogenism in PCOS is therefore a potential culprit in the development of NAFLD. And the recent meta-analysis showed that among women with PCOS, those with NAFLD had higher serum testosterone. Well, the mechanism behind this association of androgen excessive NAFLD and PCOS shown to come from the intra-adipose tissue androgen generation, which derives lipotoxicity, notably by increasing adipose hypertrophy. Third one is the hypothyroidism. Hypothyroidism is a frequent endocrine disorder defined by thyroid hormone insufficiency. Thyroid hormones are involved in various metabolic processes, including body fat distribution, lipid utilization, energy expenditure, and glucose homeostasis. Altered thyroid hormone levels may therefore participate in development of NAFLD. Levothyroxine administration has been shown to be associated with reduction of BMI, serum lipid, thus suggesting a potential beneficial impact on NAFLD. In addition, several randomized control trials have shown a reduction in liver enzymes, hepatic fat content after levothyroxine administration. Male hypogonadism. Male hypogonadism is a clinical syndrome defined by reduced testosterone secretion and or spermatogenesis. Studies in male have reported an association between the low testosterone and increased visceral adipose tissue, insulin resistance, and dyslipidemia. An increase in abdominal adipose tissue with low testosterone level may lead to hepatic steatosis, insulin resistance through the de novo lipogenesis. Therefore, low testosterone may favor uncontrolled hepatic lipid accumulation, therefore leading to NAFLD. In clinical settings, testosterone replacement has been associated with beneficial impact on hepatic fat content in animal models such as castrated rats, but in humans, the benefit of testosterone administration in NAFLD is still a matter of debate with conflicting results between randomized controlled trials. Growth hormone dysfunction. Well, growth hormone exerts various physiological action on glucose and lipid metabolism, glycogenolysis and gluconeogenesis. Due to its pronounced impact on lipid and glucose metabolism, the level of growth hormone appears to be related to lipid accumulation in liver. An association between growth hormone deficiency in adults and development and severity of NAFLD has been reported in several observation studies. Several clinical studies have reported potential beneficial effect of growth hormone administration on liver enzyme level and even hepatic steatosis. But due to limited data to date to this regard, growth hormone supplementation therapy should not be considered a specific treatment of NAFLD in patients with or without growth hormone deficiency. On the other side, growth hormone excess, it results in deleterious effect on glucose metabolism, insulin signaling, hepatic and extrahepatic side by stimulation of gluconeogenesis, glycogenolysis. Excess growth hormone causes an increase in lipolysis that lead to high level of free fatty acid and promoting insulin resistance. Few studies to date have shown an association between acromegaly, growth hormone excess, NAFLD prevalence, and in particular the hepatic steatosis index. Interestingly, a reduction of growth hormone and IGF-1 level after treatment of acromegaly has been associated with a reduction of the hepatic steatosis index. Glucocorticoid excess. Glucocorticoids may modulate several key pathways involving in lipid and carbohydrate metabolism. Cushing syndrome, the glucocorticoid excess syndrome, have been associated with a prevalence of 20% of NAFLD. In accordance with this, the exogenous hydrocortisone has been shown to be associated in a dose-dependent manner with an increased risk of NAFLD independently of the BMI and waist circumference. Excess glucocorticoids can mediate hepatic fat accumulation through several mechanisms, including the de novo lipogenesis, gluconeogenesis, and stimulation of food intake. Lastly, some miscellaneous. One of them is the vitamin D. Vitamin D deficiency has been associated with development and severity of NAFLD, subjects with normal ALT and AST. In addition, NAFLD patients have an additional risk of low vitamin D, approximately 25% compared with subjects without NAFLD. Preclinical studies suggest potential anti-inflammatory, anti-proliferative, anti-fibrotic effect of vitamin D administration on the liver. Second one is the primer aldosteronase. Primer aldosteronase is the most common frequent cause of secondary hypertension, accounting approximately of 10% of cases with hypertension. Primary aldosteronase can not only cause hypertension but also insulin resistance and dyslipidemia. It has also been reported to increase the risk of metabolic syndrome and NAFLD. The impact of therapeutic or surgical treatment of primary aldosteronase remain to be determined if it will cure the NAFLD or not. Lastly, the prolactin. Prolactin is a pituitary-derived hormone and potent enhancing effect on the reproduction and lactation, of course. Since the receptor of the prolactin is also present in liver, it
may play a role in hepatic metabolic regulation. Multiple observational studies have shown a negative correlation between prolactin plasma level, body weight, insulin resistance, and NAFLD development. Prolactin and its hepatic receptor therefore represent an attractive approach to counteract development of NAFLD. So, to summarize, NAFLD is the most common chronic liver disease in Western countries, with NASH being characterized by inflammation, hepatocyte injury with without fibrosis. NAFLD is ultimately entangled with various endocrine diseases, sharing the keystone pathophysiologic mechanism of insulin resistance. However, the pathophysiology of NAFLD in different endocrinopathies is far from being understood. Therefore, limits our capacity to more specifically treat NAFLD in this content. Consequently, it will be of importance to better understand the interrelationship between endocrine diseases of NAFLD to better target treatment. Thank you.
Thank you so much, Dr. Nahira, for your presentation, for your elegant presentation, please, and for being very strict with the time. Can you please postpone the discussion until the whole session is ended?